Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome, everybody, to Healthcare Musings. I'm so happy to have you with me. I'm so delighted and honored to have Jeff Alter. He's the CEO of Sound Physicians, the best medical practice in the country, multi-specialty. And why I wanted to have Jeff Alter on the show is because last week on the podcast I talked about the phenomenon of AI on the provider side and AI on the insurer side, and how there's just this battle of quote unquote aggressive coding on the part of hospitals, and a fever turns into sepsis, and it seemed to me to be this zero-sum game. It's like the payers have the money, the providers want the money. The providers are doing everything they can to get the money. The payers are, it seemingly, from my perspective, doing everything they can not to give the money. And it's just this endless adversarial relationship. And having Mr. Jeff Alter on the program, because he's spanned both the payer side and the provider side. And so I think his perspective would be great. And I promise I'll do my best not to get super emotional. Because it can be very, very frustrating. As a clinician, I'm a physician advisor with Sound as well, and so I see it. I see the denial and appeal side, and that can get super frustrating. So I really wanted his perspective. So welcome to the show, Jeff Alter. It's great to have you.
Thanks for having me. And yes, I do have the perspective of being on both sides. So I'll be as neutral as possible and as supportive as possible on both sides, because I think.
Thank you so much. And I guess I promise I won't take my frustrations out on you.
That's okay. That's okay. There's frustrations to go around.
For the audience's perspective, if you could kind of give us your journey from before and now to Sound, just so that they can really appreciate your perspective.
Yeah, sure. I've had probably a very long career in healthcare. I'm getting almost to a point where it's 2/3, 1/3, 2/3 on the payer side, 1/3 on the provider side. I worked for Oxford Health Plans and then United Healthcare for about 15 years. The last 8 of those, I led the commercial business for United Healthcare, the domestic commercial business. Left there, went to Anthem for a short period of time, and led their PBM. Back then, it was Ingenio RX, Caroline RX. Then I moved over to the provider side. I was the CEO at Summit Health and CityMD, and for the last 2+ years, I've been the CEO here at Sound Physicians. So, as I said, beginning to a little bit balance a 2/3, 1/3 provider versus payer side.
That's fantastic, and that's exactly why I wanted to have you. So okay, so like it's just like I said, the payers have the money, the providers want the money, and it seems like the payers are doing everything they can not to pay the money. In fact, that article that we're saying, they're talking about they're using AI to combat the aggressive coding because it's eating into their profits. How is this not an irreconcilable conflict? Because and then they're talking about, when the providers are using AI, they're increasing healthcare costs because they are, getting more bills, and that's going to become more co-pays and more onto deductible. And I took really offense to that. That's really annoying. If I'm entitled to get the reimbursement, what's the problem? How come it's my fault? Why is it always our fault? That we're if anything, we're underbilling, and then when we finally get to what we're owed and what we deserve, healthcare costs are going to go up. How is this not an irreconcilable conflict?
I will tell you, I'm probably somewhat happy I'm at the end of my career in healthcare and not the beginning of it, for as long as I've been in the healthcare industry, the friction, the cost versus, who's paying for it. I think, I'll start with there are vast majority of good people on both sides, and I think we've set up the insurance companies, and just again to kind of To put a little perspective, you know, the I'd say 95% of the payments made by payers are on behalf of others in the health in the marketplace, not their own money. Very few dollars of a payer these days is from a fully insured model. It's mainly self-funded or government pass-through, whether it be CMS, whether it be state Medicaid. And in the business that I ran at United Healthcare, we had a little over 30 million people that we provided payments for coverage for. Um, 27 million of those people were somebody else's risk, mainly large employers or mid-sized employers country. So in many cases, we've set up the insurer or the payer to be the police of the system. And with everything, it's down to the lowest common denominator. So there's plenty of fraud, waste, and abuse in the system. And unfortunately, the rules um, favor the payer to get at that fraud, waste, and abuse, and then unfortunately suck everyone else in. And again, the vast majority of uh, providers in this country are just trying to do a really good job for their patients and get paid what's due them. There was hope that at some point the data interchange and the ability to have everything in an electronic health record would actually make things easier. I actually, in between my time at United Healthcare and before I went to um, Anthem, was trying to find a way to invest in a, a technology-led system that would, for the most part, wipe out denials and get everybody to have less friction in the system. Because at the end of the day, it's the average American that feels the pain of that friction, whether it's denied care, whether it's delayed care, or their trusted physician not getting what they're due. So the real struggle is getting all the right people in a room to have this aligned so that you can get everything done correctly and appropriately. And I know from my most current time on the provider side, there's an awful amount of time and effort wasted by remarkably talented clinicians who could have more time with their patients, who could have more time for a work-life balance, who really are spent either over documenting or fighting with everything that goes on. So it's something that we have to get at. And I think the only way to really, really get at it is to have a different mechanism for reimbursement. I do think that value-based care is the way to go. It needs better technology. It needs better cooperation across that local healthcare community. And I think the key is it really does have to be done at a very local healthcare marketplace level. And we're seeing the failure right now of the exchanges once again. The reality is we don't have a national healthcare network or a healthcare system. And when rules are made in a central organization across thousands of local marketplaces, it just causes issues. And I think solutions have to come from those at the state or local level who can bring health systems, independent providers, physicians, clinicians, extenders together to create a payment model where you're rewarded for keeping somebody healthy, you're rewarded for getting somebody through the system appropriately, um, and eliminating extra testing, eliminating wrong diagnoses, eliminating, what I would call the churn that sometimes happens. So, it's a daunting task. It's a complex issue. you know, I used to joke when in my later days at United Healthcare because I'd be sitting across the table from the folks at Optum who, their revenue was my expense. And, in a single room, we had, we could describe the complexities of the healthcare system. My desire to reduce excess costs for my clients, mainly large employers or employers across the country, um, went against the revenue model of my colleagues that were providing care. So it is, my belief is the issue that we face day in and day out is that somebody's expense is somebody else's revenue, and it's it. I think value-based care and aligning incentives across small delivery systems in local markets are the way to go. But again, even on the physician or the provider side, we're all in competition, right? No matter what what market you see, there's more than one or two or three health systems that are all vying for patients and vying. Um, Patients have free will; they get to go to all different systems and providers. And how do you tie that all together so that that best care is delivered? I think that's the challenge. We have an expensive system. Um, Freedom is expensive, and I don't think the alternative of a nationally run healthcare system is the way to go, where everybody's taxed and healthcare is free, and yeah, that would not fit with the ethos of the free American society. And people don't want to be rationed, which, people will talk about how well healthcare happens in Europe or Canada or other places. And the reality is when you dig into that, there's a ton of rationing. There's a forced end of life procedure that we as Americans, I just don't think would ever accept that for the off, offset of quote free healthcare. So,
That's very interesting. But isn't like we have a government healthcare called Medicare, right? And Medicare Advantage, and they set the prices and they set the rules and they set the terms, and for the most part, people like it. Number one, and number two, isn't the so we kind of have that already, and they do kind of ration. It's not like you can do whatever you want. I mean, if Medicare doesn't cover it or something, but then you've got the Medicare Advantage, which layers their stuff
rules,
on
yeah,
top of it,
yeah.
which then adds to the frustration. So it's not like we have a completely free marketplace. And if we collude as clinicians, it's we're like we run afoul of antitrust
Right.
legislation, right? So we're it's a zero-sum game, but they make it that way. I can't collaborate with everyone because then I'm colluding, right?
Right,
And
and that's
price
where I
and price
think,
fixing.
yeah, I think part of our um, complexity of our healthcare system is because of how dominant, Medicare and Medicare reimbursements have been, and the stroke of the pen reduction of cost. Having now been on the provider side, I will tell you, you cannot run a multi-specialty, a high quality multi-specialty physician group on only either Medicaid or Medicare rates. And, the offset has been commercial rates. And so every time CMS or the states cut Medicaid rates, we go back to the commercial side of the payers and ask for more premium from them. And for the most part, that's been going on since 1965. And, the average commercial rate is 2.5 times the Medicare rate, and it's probably almost 4 times the Medicaid rate. And so, I think right now our safety valve to the government run programs have been commercial. If you were to take that off the table, we'd have quite the crisis in healthcare in the United States, because I don't think there would be enough delivery of healthcare because, talented physicians would decide it's just not worth it anymore to make less money, because we didn't have the commercial rate. I do think there are a lot of things, as I say, you gotta be careful when you point fingers because three fingers point back at you or other people in the system. We have to fix tort reform, right? That drives up healthcare costs. We have to fix the Stark laws and the anti-competitiveness for people that are coming together for the right reasons with the right payment models. I think CMS, CMMI threw out the baby with the bathwater when it came to the pilot program for bundled payments. I think bundled payments across a local healthcare delivery system are are one of the answers for the future. And we have to modify some of the antitrust Stark laws that were, quite frankly, put in, um, 30, 35 years ago when we were almost entirely a fee-for-service indemnity world, healthcare system. And that's no longer the case. Vast majority of our payments are either capitated, or driven through some sort of cost share from our patients. So there's, it's a different world. Um, Unfortunately, we're going to need bipartisan approaches, and that seems to be an even more difficult, um, concept these days. But hopefully we can get enough like-minded people that may have different ideologies in a broad sense, but understand, like, as I always would say, I don't think anyone in government wants companies inside the United States to have a significant disadvantage to their global competitors because of healthcare, and they do. And so maybe we can find that as the common middle ground to say we need to eliminate the anti-competitive healthcare system we've imposed on our large employers in a global economy, as a negative, and can we balance that? But I think you've got to work on tort reform. I think there's got to be caps on what people can sue and how they can sue and when they can sue, and what the damage amounts, it can be, for what I would say a relatively small medical group that we have here at Sound Physician. We pay an extreme amount of medical malpractice insurance. That's not helping anybody. That's not delivering better care. That's not doing anything but, basically covering some uh, tort attorneys and some really outsized jury awards on minor, everybody. I think we have to find a way to believe that honest mistakes happen, and those are not the things that should be punished by huge amounts. Negligence is one thing, honest mistakes is different. So we got to work there. I think we do have to bring um, healthcare system together, and we've tried now twice by saying it should be primary care physicians. And we tried that in the HMO era, and then we tried it again over the last 7 or 8 years with the value-based constructs and global capitation. In reality, it's only worked in one place, and that's Southern California, and that's only because that's how that marketplace developed. Imposing that has not worked. And I love primary care physicians, but at some point, somebody gets sick enough that they have to go beyond the primary care physician. They have to go to a specialist. And as soon as that specialist is fee for service, um, that's not going to work. And every once in a while, people do have to go to an acute care facility. They have to have, aftercare. They have to have a transition of care. And to make that work right, we have to have people working together. And to make it work together, we have to align the incentives for that. And I think, the reality is only government can make that happen, because individual companies, entities, delivery system side, that would be probably far too disruptive, and nobody's going to have that crisis moment that makes it. We had that crisis moment in COVID. I wish we could recreate the American ingenuity that happened in those early days to, to face the fact that we have a crisis now that needs to be attacked. Now, I think over the next 6 to 8 months, we've seen it already in the shutdown. Healthcare is now had fallen down the list of priorities for people. I think it's now moving up to the top. It drives affordability. It drives longevity. And so I think healthcare is going to come back up to the top as a discussion. People are seeing big premium increases. Companies are seeing big increases. Um, and I think we're going to get at a moment where hopefully we can get the right people in the room to say what we're doing today or what we've tried in the past needs to be looked at. And with the growing use of, with the ability to have the data that we have, to be honest, one of the reasons why I looked to move over to the provider side was because for years, I just hoped that people could understand that not everything your insurance company tells you is in their best interest. It really is in your best interest. We sat on a lot of data. We knew journeys of healthcare, and if we could just get people to sort of get on the right journey, they get better outcome. They get lower costs, but because it was coming from the insurer, it wasn't going to work. I was anxious to move to the provider side because at the last few years on the payer side, I realized if healthcare is going to improve in the United States, it has to be changed by the people who deliver the healthcare, not who pay for the healthcare. And then if we can change the way it's delivered, then we have um, a voice in the room to talk about how do we change the way it's financed. So then, of course, I've learned the complexity of stock laws and self referrals and all. There are right ways around it. We have a really high performing ACO in long term care at Sound. Um, we don't actually deliver any of the care. We have partners that do it, and we've been able to save in the most vulnerable feral population, on average $10,000 a year for those folks. Just keeping them healthy, keeping them, um, giving them the ability to get care as quickly as possible instead of sending them to an acute care facility where they really don't belong. Um, and so I know I've seen it there. I saw what was happening in BPCI, the bundle payment program that CMMI ran a few years ago. It delivered significant savings and a better outcome for people. And so I know there are constructs that can work. We just got to get back to those, um, and do them. And this is where I think AI and technology are our friend. We need to do them in a way that they can be customizable, thousands of ways to fit the local healthcare delivery system, um, at where it is versus where somebody believes it should be, right? And be able to do this at scale across thousands of different local marketplaces.
Yeah, absolutely. And I'm going to have the Sound ACO people on the podcast because Sound figured out how to do it right, and we're number one in the market. So that's
Yeah,
really awesome.
yeah.
Especially with long
And
term
again, we
care.
don't. It's not our physicians that are delivering the care. We're actually acting as a conveyor, with bringing in the information. We've we've been very careful in working with those that are willing to be engaged and willing to do things differently and are willing to, you know, um, run into a sniff at a short notice to take care of somebody who is having an episode that could wind up, inside an acute. facility if they don't intervene. And we've been very, very fortunate to be able to have the right partners, and, and do right by the system and do right by that patient and their families.
Yeah, that's how that's awesome. I look forward to having them. So, a
Yeah.
couple questions that brought in my mind. So, when insurer increases premiums, to me, and you tell me, to me, they're just, oh well, the shareholders need their margin, and I'm a shareholder,
Yeah.
right? I have a retirement account. They're almost all in equities, right? And I want to fund my retire. I want to retire one day. As much as I love being a doctor, I want to retire one day. So I get it. I want value for my share, for my what I'm holding. At the same time, when I see it, they're increasing their premiums by 20, 11%, 12%, whatever it is. Well, they just got to maintain that level for their shareholders. Why is that my fault? Why do they do that, right? If it was working great this year, what's different?
So, yeah, I think part of the optics are that we've boiled down the payer world into what I'll call four mega payers, and then a very small group of other payers. Um, you know, Profit margins are actually lower on a percentage basis at the payer than they are at the provider side. That I know. Um, The ACA, the Accountable Care Act, limited the profitability of insurers to 85% for government programs and large businesses, and 80% for small businesses. There's a higher admin fee for small businesses. It's mainly due to their brokers. So, the brokers that are involved in the small businesses take about 4% of premium to be that trusted advisor to those small businesses to choose right. So, um, at most, which this never would happen, but if a payer figured out a way to not have any administrative costs, um, the most that they would make is 15% on. So, but that's not true. There are thousands of people that work there for paying claims, processing claims, medical management, creating networks, and working with physicians downstream. So, on average, the what I would say the real margin of payers is somewhere in the mid single digits, 5-6%. Now, that's on billions of dollars, right? It's hard to fathom the scale of the numbers at somebody the size of United Healthcare. I used to go around to our operations people who were really proud, and rightly so, of having a 99.5% accuracy level. And what I would say is that's great, but we disappoint the city of Cleveland every day. We had 50 something million members, right? If you multiply that by a half a percent, get where we were getting it wrong, you disappoint a lot of people. And
Yeah,
so it's just the scale. So yeah, United Healthcare at the end of it all makes, you know, billions of dollars. But they also pay about $40 billion of claims. So 5% of 40 billion is still a lot of money, but it's 5% of that. So I think unfortunately they become easy targets because they've consolidated so much of the market, um, and they've been asked by governments and commercial employers to be the police for the system. So they sort of do pick up a bad rep. Now, some of it, yeah, I scratch my head. I was just reading the other day about um, and it doesn't impact sound physicians, but it does impact primary care physicians, including pediatricians who barely make a living these days, where Aetna and Cigna are automatically downcoding the 99 to 15, which is the high level office visit down to a mid-level office visit, you know, and it's leaving it up to the provider to send in the records to get it up back to what they said. And to me, that's just completely wrongheaded, particularly these days where there is data interchange that could defend those easily without just an automatic denial. And so I'd say there's uh, stupidity happening on all sides.
Yeah.
And it's a little it's less concentrated on the provider side, so they're not as easy targets as the payers are. But they're we have um, we have competitors to Sound Physician who believe that a non-network model is the right way to go. As you know, our belief and conviction is, uh, we've created a medical group who can survive on network rates, in-network rates. For the
Hmm.
most part, we're more than 90% in network as a organization. Um, to me, that's unfair to a patient that gets brought into an emergency room and seen by a physician in a crisis, who's non-network. And now instead of getting covered by their full coverage, they're into their out of network or out of network deductible. Same way in our hospitalist model or our critical care model. So I think there are unfortunate players on both sides that are there to line their own pockets over somebody else. So I think there is enough blame to go around. There's the last estimate that I saw that there was over $40 billion worth of waste in the U.S. healthcare system on fraudulent providers, right? So it's just that there aren't four mega providers in the country, and there are four mega insurance companies and
Right. Right.
there. So
So, but how
yeah,
is
I wish I could say there was an easy solution to that. The solution would be the government, and I mean we're seeing it right now with some misguided cuts to MPFS on facilities because CMS didn't understand that there are medical groups like us who practice inside hospitals that actually do have administrative burdens that are not covered by facility fees. So,
right? Right. How is it that when, for example, my kid needs a special antibiotic, and I'm waiting for prior authorization,
yeah,
right? Because it's not a generic, it's not generic anymore. It's still not generic. How is it that they seem to me as a patient, they're practicing medicine. Why are they seem to be practicing medicine, right? They're saying this is not covered because there's no whatever, or no, we're going to deny this because of this.
yeah,
You're not a physician, you're not an APP, you're not a clinician. It seems to me that the insurers are practicing medicine, and then they get none of the liability we do,
right,
right? If I'm the one with the liability gun to my head,
right.
they're not.
Yeah, and
How
I
it's
think
it's very frustrating
I think
from our
the
perspective.
that starts with the early discussion around tort reform. I think it is unfair that if we're doing the right things and following guidelines that are whether it's the federal government or state governments or payers that ask us to do, and if that causes a delay in care, we're the ones that are accountable and responsible, and the ones that the lawyers will go after. Um, I would say for the most part. I'll speak for at least two out of the big four because I work for two out of the big four. Um, there is a very, very um, strong set of policies and rules that do not allow non-clinicians to make clinical decisions inside those. So, I had a very large group of very talented clinicians, physicians, who would do the reviews. And like in everything, sometimes we're not getting the payer didn't get the full information or didn't didn't understand the nuance that was going on. And many times it basically was a phone call, and the two clinicians had a meeting of the mind, and it was quickly resolved. I think where we are going a little bit astray is relying solely on third party published guidelines. So, there are quite a few companies that provide sort of clinical guidelines.
Right.
Um, and those clinical guidelines blindly implemented are causing too many issues. Um, when a clinician can speak with a clinician and have a conversation, those generally work out best for everyone. And it's these implementations blindly of clinical guidelines. And listen, eh, um, we have this debate on a regular basis between, thousands of nurses, thousands of clinicians. Um, you know, we tried, gold carding and dropping prior auths except for the most complex. Why? Because, when you talk about the 15%, a good chunk of the 15% of admin costs are clinical teams. Just in the commercial business of United Healthcare, we probably had close to 25,000 nurses, nurse practitioners, specialists, primary care physicians that would have conversations with their counterparts that were delivering the care. Believe me, if we could have reduced that, we, that would have been a big plus. We automated the claim systems, but it wasn't the right thing to do, and it was very difficult to do to automate but I do believe people are using, my old colleagues on the payer side are relying too much on third party clinical guidelines as the sledgehammer, as opposed to what I would say the old model of a disagreement or a misunderstanding where a United Healthcare physician called you and said, "Hey, tell me why you want this, because I don't see it." And you say, "Well, okay, I understand. It's approved." Right. I mean, there were times where I would get the CEO of a large organization's wife with a denial, and they would call and ask me to override the denial. I did not have that power. I could go back to the clinical review team and say, "Hey, is there any gray area in this one?" And if it is, could you put your thumb on the scale? That sort of thing. But that was the limit of what a non-clinician could do. Right?
Yeah. So should insurance companies be nonprofit? What are your thoughts there?
Yeah, so here's what I would say. Probably if you took out the mega four, the Cigna, the Aetnas, the Anthems, and the Uniteds of the world, a vast majority of the local insurance, including most of the Blue Cross Blue Shield system, are nonprofits. Um, so, but I would say what happens there is they still have to compete, right? And so, many of the same techniques that the larger for-profits, who, as I say, had their profitability capped, um, they still have to compete. So if they let their costs go well above everyone else, and their premiums had to increase, and their premiums were higher than the big four, they would lose market share. So,
Right.
I'd be careful about that. As an easy solution. The same in the provider side. Some of these large academic medical systems will claim to be nonprofit, but they spend an awful lot of money on advertising and putting their names on football stadiums, and
Yeah.
so uh, you know, define what not nonprofit is. Is it spending all your money, or is it actually having a mission that that does good for people?
Wow. Yeah. That's actually a very good point. So do you do you see, we're wrapping up here. Do you see, so I know that sound has figured out how to make it work in a different model.
Yeah.
What's your kind of sense? Are you optimistic about the future, or does it have to reach a crisis point where things have to, which is always never good, like you were saying, it's very disruptive. What's your sense of the future?
Um, I mean, I'm an optimistic person by heart. I do think there's hope. I think if you get right-minded, well-intended people together, um, I don't think you can do it nationally, but I think you can do it, in some large markets if you get the right people together in those markets, along with the right regulation and legislation to allow um, experimentation. And again, not experimentation on people's health, but experimentation on models of both financial and health outcome accountability. And so I do have hope. I said it before. It For the most part, it's worked in Southern California because that's the way that market grew up. Can we find a way to create a system that works in Miami-Dade County or New York City or Boston? Um, Again, I think those are three different models, but can we get the right people together in the room for those three models to begin to um, percolate and experiment and get it up and running? I do. I, as I said, I've had a long career. I used to, when I first joined, some of the folks that I started working with when I was in my 30s that were at my age would say, "Oh, um, when the family premium goes above $10,000, that's it. That'll be the crisis. That'll create everything." Well, the family premium is about $26,000 right now, so they
Yeah.
weren't great steers of the future. And you brought up the medical trend. Our organization is self-funded. We pay an admin fee and for United Healthcare to manage our program. That fee has gone down in the last 3 years, and we just got an 11% increase, and that 11% is all because of medical costs. There's no United Healthcare profit in that, and so people are beginning to see. We and here's where I'll say the system today is kind of unfair to the provider side. Out of COVID, we had a labor shortage. We had clinicians that we had to pay more, but our contracts with payers were 3 years, and we weren't the only ones. There was a definite inflation around labor, COVID and post COVID. Well, the provider has been eating that while these 3 year contracts have run out. And now we're in the season, for the most part, of renegotiating with the payers. They see it. It's not like we're trying to tell them we want to make more profit. We just want to pay our people that we've already paid, and we need to get that back. So we're in a cycle right now where we see these increased costs. And then, we're in a cycle of, ever needed, which is always the struggle, right? Ever needed high cost drug therapies, right? This is not about the $3 penicillin anymore. These are about rare diseases that have virtually no cures. Pharmaceutical companies have spent billions of dollars. They have cures or treatments, and the treatments are outrageously expensive.
Yeah.
Um, so this is the alternative, right? Do you not give hope to those 15,000 people who have that rare disease that some drug company just figured out how to make their life better with, and it's $45,000 a month? Um, and so that's that. At the end of the day, I try, and I think it's because I've been on both sides. I've seen the struggles. I've seen the complaints by my clients about driving up their healthcare costs and me not doing anything about it when I was on the payer side. So I think I have enough sympathy for everyone in the system
Yeah.
um, to say if we could get by pointing fingers at each other and could get in a room and work together to say, how do we, as patriots and freedom loving Americans, how do we take that and create a better healthcare system? Um, that, maybe I'm a little Pollyannish, uh, but I hope we get to a point where we can. And if we can just do it in a few markets and show that there is a path forward, I think that gets us to a national solution. But that national solution is 1,000 different ways of doing it.
That's perfect. That's a perfect way to end. And hopefully we can figure it out without having this endless
Yeah, I
acrimony
don't
and
think
endless
anyone is going
adversarial.
to like a fully. I don't think anyone in the United States will will. They think they'll embrace a government-run healthcare system. They will not like a government-run healthcare system. The providers won't. I mean, you just look at the salary of an orthopedic surgeon in Germany or in England versus the orthopedic surgeon here. Um, they couldn't pay their medical school bills on the salary that they would make if it was a government-run healthcare system. Right?
No,
So,
that's
yeah,
true. That's true.
yeah,
But there's free there. It's not free here. Yeah,
yeah,
like you said.
right, yeah.
Yep,
So, well, it's
absolutely.
been
Well,
great. Yeah, I wish I
Jeff
had
Alter,
solutions.
this
I
has
guess
been
if I did,
fantastic. Thanks
I
so
guess
much
if
for
I
your.
did, I'd be a saint. But yeah, but I think, I think there are enough good-willed, smart people inside the healthcare system that if we could get beyond what we disagree on, and get to what we agree on, we could come up with better solutions.
Absolutely. Yeah, that makes total sense. Jeff Alter, it's been a pleasure having you. Thanks for your insight. Thanks for your wisdom, and this is going to be very very helpful for the audience. So thanks so much for your
Great.
for your time today. Thanks for being on the
All
show.
right. Thanks for having me. Talk to you soon.
Absolutely. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.